Wonderful conference, and first time we are meeting after so long time, so thank you for inviting me. So my talk is not that advanced as my fellow speakers, but I think this is more important in present scenario that we are facing more with these kind of problems. Like a patient, this is a real patient, presented just 1 month back, 56-year-old presented 4 hours after his chest pain to a local hospital, and angiography was tried because of an inferior valve MI, but ultimately the right coronary artery could not be hooked, and he was not thrombolized because there was some suspicious history of some stroke which was not very clear, and he was referred, and ultimately he reached almost, what is happening with this, more than 24 hours after the presentation to the hospital. So as we are already discussing that the major determinant in outcome is time, but time is not the only component. So I think the major issue is how to reduce this time delay and how patients should reach early in time, then to discuss how to do with these patients who are coming late. But definitely if they are coming late, something has to be done for them. So the guidelines are also quite deceptive. The ACC guidelines gave this a class C indication sometimes that if patient is presenting after 24 hours and the chances of recovery are much less and they can be subjected to some kind of further investigation before you should go for intervention. ASC guidelines in 2017 updated it to class 2A indication up to 48 hours. And after 72 hours, it is very clear that only patients who are having evidence of reversible ischemia or viability, they should be subjected to intervention, otherwise medical therapy is sufficient. The problem with all these data is that most of the data is based on the thrombolytic era, not on the newer era, because the newer studies are very minuscule in this field, and the major knowledge we are having is mainly on the canine data from Remer et al. This was in 70s, and when he presented that after 24 hours, most of the muscle is dead and there is no chance of revival, which is an experimental scenario where the arteries are blocked in vitro, and that caused this data to come. Again, all the data which is saying that patient presenting after 24 hours, the benefit is not much, is mainly very old. And after advent of new drugs and new interventions, there are very few trials which have shown that it is beneficial. But at that time also, Dr. Brandwald has that vision that he has hypothesized this open artery hypothesis based on the theory that all the patients who are coming with a flowing artery, even after late presentation, are having better outcomes as compared to patients who are presenting with a closed artery. So that gives the background that ideally they should be opened or not. So there are multiple theories and hypotheses behind this, that patient can have intermittent flow in between because of autothrombolysis, patient can have hibernating myocardium, patient can have ischemic preconditioning, patient can have collateral circulations. So thus time is the most important factor, but there are many other collaterals which are to be assessed. There are multiple other theories given that accelerated healing in infarcted artery and absorption of myocardial debris. If you give the flow, then the remodeling is better, then patient heart dilatation is much less. So all those theories are given to prove that late reperfusion is not that harmful and maybe sometimes beneficial. Again, the benefit is proven only in few patients, not in all. It was only maybe in 40-45% of patients that they have proven some benefit. BRAVE 2 was, I think, the first trial in which angioplasty was included, and it showed that after 48 hours, within 48 hours, if we are doing angioplasty, it is better than conservative therapy to some extent, although the total outcome is definitely worse if patient is coming late. So this has given some data that we should do intervention in these patients, but then came the old trial, which again was very old, 2006, which showed no benefit. Although in old trial, the sub-study showed there is some improvement in LV function and LV mass index and LV end-diastolic volumes in patients who are intervened, but that could not lead to a clinical benefit, which is quite deceptive because possibly the number is less or the duration is less. Otherwise, we know that if we improve the LV function or LV volumes, then definitely this should come out in terms of outcomes. So multiple trials are done, and ultimately they all are touching the midline. So the superiority of intervention over medical therapy was not proven in these patients who are coming late. But they have multiple limitations also. I will not go into details of all these things because in these kind of situations when patient is coming late but is in between time, You don't want to delay these patients for further investigation and to decide something. So in 2009, again a trial came which showed that patients who are coming within 12 hours versus 12 to 72 hours. This is mainly the trial which showed that if we do salvage, almost 40% of late presenters showed some decrease in infarct-related the total salvage myocardium and infarct-related artery angioplasty. So there is some data which says that up to 72 hours, there is some benefit in terms of outcomes if we do angioplasty. Then the latest trial, the data is coming from the Korean registry, which showed that if patient is coming late, outcomes are definitely worse if we don't intervene them. Although the number of patients who are presenting late is just 15 to 20%, most of the European and American studies have shown that the number of patients presenting late is less than 15–20% now, but in India, I think it is more than 30% still. So more is to be done in that scenario instead of deciding that should they be intervened or not. Definitely, we all know that outcomes will not be worse if we are doing it very late, and the patient presenting late will fare worse in future course. The latest trial, which just published last year, showed this is a registry of 3 trials, fast STEMI from the French registry. This again showed that patients who are presenting within 48 hours, but after 12 hours, they showed that there is some benefit in terms of outcomes. You can see this is still significant benefit in terms of long-term mortality, even at 3 years. So this data say that at least up to 48 hours, we can intervene, and there is no need to wait for the viability studies, even if the artery is totally blocked. So there can be multiple scenarios, like patient can be symptomatic or asymptomatic. In symptomatic patient, I don't think there is a question in terms of shock, in terms of ongoing ischemia, in terms of dynamic ECG changes or arrhythmia, angioplasty is advisable. But for asymptomatic patients also now with this data, we can at least give them some benefit in terms of long-term outcomes, may not be the short-term outcomes or improvement in LV function. So the treatment study can be planned accordingly. For a patient who are coming within 48 hours, they should be explained that the benefit will not be that much, but at least they can be given the option of going for angioplasty with some benefit. But patients who are coming after 72 hours, I don't think there is any data available to prove that they are benefited by revascularization in all patients, as our trial has clearly shown that there is no benefit. Although in recent trials of MRI-guided viability testing, it is proven that there is no correlation between time delay and myocardial salvage or myocardial damage. So there are multiple other factors involved, and that requires more evaluation that how to choose right patient who will be benefited. But till that time, all patients who are having a occluded artery, they should go for a viability testing. Again, patients who are coming after 72 hours and having a flowing artery, it is debatable to do what to do in these patients. Should you subject them to a viability again, or should you leave them on medical therapy, or should you revascularize them? So there is no data available on this study. So again, in the same patient, it was difficult to hook this patient, and ultimately with side branch anchoring technique, angioplasty was done, and patient recovered very well, and his EF also recovered in the immediate past. Another patient also, so as we all know that we already discussed about the shock patients. If patient is coming in shock and coming very late, still they can be benefited. So this is another example of a patient who has single surviving graft. Lima graft is flowing, but the LAD is totally diffuse disease. And possibly this graft has recanalized because patient presented with acute MI with a very serious heart failure and intubated but recovered after some time, and ECG changes also resolved. So this again is showing that very difficult calcific lesion in a post-CBG patient. Multiple techniques are tried, antegrade, retrograde, and finally antegrade technique is possible, but again stent was not going. And then ultimately you have to use an ultra-thin neurogeneration stent to achieve a good result. So this is the final result. And again, this patient came with just 25% EF, and within no time, he recovered his heart function, and he is in class 1, and he is still coming for follow-up. So definitely, I want to conclude with my talk with this, that patients who are coming late, the more important issue is that if they are coming late, the treatment is denied. So we should do more to reduce the number of patients who are coming late. So we have to have more awareness. We have to choose patients who may have a silent or late presentation, and we have to do something to assess that they should not be coming late. And ultimately, if patient is coming late, it is never too late to do the right thing. If it is indicated, definitely we should do revascularization. Thank you.
Thank you, Dr. Chauhan, for such a wonderful presentation. Short comment that all totally occluded arteries are not really totally occluded, because we have data from the Decopi trial and other trial, registry also, that in 30% patients you can have some collateral flow actually. So if you have collateral flow in the blocked artery, it means there is some viability. So one should not leave those patients, because that is the time when patient is on table and you are seeing a blocked artery and you are taking no blocked artery and we will not do anything. So if you are having some minimal to moderate collateral flow, one should do the intervention. My question to you, that now the PCI is available in small centers and they are doing these procedures, and especially in MI situation. And the viability study is very difficult to do in those scenarios. So what can be done in those patients, those centers, to short of MRI and nuclear scans which are not available to them, to avoid the time delay?
So I think till 72 hours, I don't think we should wait for viability study. They can be subjected directly to intervention. All those patients who are coming after 72 hours, we can have indirect evidence from at least echo, which is always available. So if echo thickness of myocardium is less than 7 millimeter, it is generally considered to be non-viable. So that is true for all patients, and we can take that as consideration and use that for our viability assessment. That is the only way we can assess it.
Any comment from the panel members? How you assess viability in your patients? Because I think nuclear scan is not available in your center.
Nuclear scan is not available, and we generally, as sir said, we generally follow the echo rules. That's available at and also because when we used to send the patient for nuclear scan, they gave a date for another 10-15 days, so there's a lot of wastage in the time. And most of the people, even in the tier A cities, they are not well, as far as the MRI is concerned, the interpretation of the cardiac MRI, it is not that level, even though we have a available radiologist, consultant radiologist, but cardiac MRI is still some lacunae.
So echo parameters are, subtle echo parameters are important. Dr.
And also, like you said, the collateral supply from the other vessels.
Yeah.
That's also very important.
Yeah, that's the time that we have, Mr. Chairman.
And the dictum is that open artery is better than a closed artery. So, of course, the echo is in such centers a gold standard, and we can find out the thickness. And if the patient is too late and if it's very thin, then of course there will be no point in going for that intervention in that patient.
And one very interesting observation, that whenever we have a patient, acute MI 3 days back or 4 days back, and he's saying he's not having any symptom. And you have the parameters, echo parameters, thus that artery is probably supplying a viable territory. And you do the PCI, then ask the patient, do you feel some relief? Then most of the time he says, yes, now he's feeling some lightness in the chest. So probably these patients are sick patients on the bed, immobilized, and they are not able to complain the symptoms. And they say that they have some relief in the symptoms. They were not able to say before the procedure, but after the procedure they always say, yes, now they are feeling well.
So definitely for patients who are coming after 3-4 days, it is still challenging, but you can give benefit to at least 30-40% of patients who will have some viability. But they should know that it's not like that their heart function will recover, because what they expect from angioplasty that the heart will become normal and all those things, so they should be explained about all these things, that's why we are doing it.
I'm sorry for the interruption.
Thank you, Dr. Chauhan.
Thank you. And